Hi, my name is Patro, and I'm a sophomore from Northwood High School, Irvine, California. Imagine two children side by side in a preoperative waiting room. Same age, same diagnosis, same procedure. And when the anesthesiologist reviews their charts, they have the same preoperative anesthetic risk assessment, ASA score. One of them is going to have a 2.3 times higher risk of an anesthesia-related adverse event. The difference isn't visible on any form that is currently required to fill out. That is the problem this research addresses. The research I'm presenting today is titled Nutritional and Socioeconomic Gaps in Pediatric Anesthesia Risk Stratification. This is a systematic review combined with a secondary analysis of two national datasets, and it resulted in the development of a new preoperative screening tool called the PAEST, which stands for Pediatric Anesthesia Equity Screening Tool. The central argument of this poster is that the global standard for preoperative anesthetic risk assessment, the ASA Physical Status Classification, has a structural blind spot. It does not account for nutritional status, food insecurity, or socioeconomic disadvantage in pediatric patients. And that blind spot has measurable statistically significant consequences for children from low-income households. My research documents that blind spot, quantifies its consequences using national data, and proposes a practical, evidence-based solution to close it. That blind spot has real pharmacological consequences. Iron deficiency. When ferritin falls below 12 micrograms per liter, oxygen delivery drops at induction and emergence is prolonged. Protein calorie malnutrition. Propofol is 97 to 98% protein bound. Low albumin elevates the free drug fraction, meaning a child on a standard dose receives a pharmacologically higher dose than intended. The risk is respiratory depression. Vitamin D deficiency. Below 20 nanograms per milliliter, the neuromuscular junction sensitivity is impaired, producing delayed recovery from neuromuscular blockade. Chronic food insecurity drives systemic inflammation and bronchial hyperreactivity, raising laryngospasm risk under volatile agents. These mechanisms are not theoretical. They are established pharmacology, taught in medical school. What is not established is any preoperative tool designed to detect them before a child reaches the preoperating room. The evidence, 3 phases, 1 consistent signal. This research has 3 phases. Phase 1 is a PRISMA-compliant systematic review. 1,247 records screened, 38 studies in the final corpus spanning 2010 to 2025. The headline finding, 81.6% of those studies reported a statistically significant association between at least one nutritional or socioeconomic variable and an adverse perioperative outcome. This is not a marginal signal. Protein calorie malnutrition showed significance in 90.9% of the studies examining it. The highest rate in the corpus. Iron deficiency anemia, 85.7%. Vitamin D deficiency, 80%. Phase 2 uses 2 national datasets. From NHANES, the National Health and Nutrition Examination Survey, we find that 34.2% of children from households at or below 130% of the federal poverty level has at least one measurable nutritional insufficiency. Among children above 400% of FPL, that figure is 11.7%, a nearly 3-fold difference across the income spectrum. In a preoperative waiting room of 10 children from the lowest income households, approximately 3 of them are carrying an undetected pharmacological risk factor. No component of the current preoperative evaluation is designed to find any of them. From the kids inpatient database, we find that children in the lowest income quartile experience anesthesia-related adverse events at 2.3 times the rate of the highest income quartile. P-value less than 0.001. And here is the most important analytical result in the study. That finding persists after full multivariate adjustment for ASA class and procedure type. When you control for clinical severity and procedure complexity and the gap still remains, what is left is unexplained variance. And that unexplained variance is explained precisely by the nutritional and socioeconomic variables that ASA does not measure. The tool. What PAEST does. PAEST, the Pediatric Anesthesia Equity Screening Tool, is a 6-domain binary scored preoperative screening supplement designed to be completed in under 5 minutes by a caregiver or clinical staff member. As a direct adjunct to the standard AASA evaluation. The 6 domains are food security status, meal frequency, and growth percentiles, household income relative to the federal poverty line, iron deficiency, anemia history, vitamin D level via a targeted blood work trigger, and primary care access as a structural determinant of nutritional surveillance. Every domain was required to have confirmation across at least 5 independent peer-reviewed studies, national dataset corroboration, and a documented pharmacological mechanism. Each domain appears in the ASA classification exactly 0 times. Scoring is simple. 0 to 2, standard protocol. 3 to 6, the anesthesiologist is notified. Targeted blood work is ordered. CBC, ferritin, albumin, vitamin D, and an individualized care plan is developed before the procedure begins. Think back to those 2 children in the waiting room. Child A, normal ferritin, normal albumin, sufficient vitamin D, high-income household, regular primary care. ASA Class 1, PAEST score 1, standard protocol. Child B, ferritin of 9, albumin of 2.8, vitamin D of 13, household at 130% of FPL, no consistent primary care. Also ASA Class 1, PAEST score 4, blood work ordered. Individualized plan developed. Risk identified before she enters the operating room. Based on our NHANES analysis, the profile of Child B represents a real and common clinical presentation at safety net hospitals and federally qualified health centers across the United States. Impact and close, what this changes. The projected impact of PAEST implementation is measurable across 4 outcomes. The income stratified adverse event differential from 2.3 times the baseline to 1. Undetected high-risk patients from 34.2% to approximately 8%. Hospital length of stay from 3.8 days to 2.2. ICU admissions per 100 surgeries from 1.1 to 1.9. And preventing a single anesthesia-related adverse event yields an estimated reduction in hospitalization cost of between $12,000 and $28,000. The implementation pathway is deliberately low barrier. No specialized equipment. No additional clinical visit. Caregiver administered, language accessible, and EMR integrable, which means PAEST can eventually become a passive safety check running in the background of every pediatric preoperative workflow. The next step is prospective multi-site validation at safety net hospitals and federally qualified health centers with EMR integration for automatic risk flagging. I want to close with this. Children cannot choose whether their household is food secure. They cannot choose whether anyone ever measured their ferritin. They should not face 2.3 times the risk of an anesthesia-related adverse event because of circumstances entirely outside their control. The evidence to close that gap already exists. PAEST is the clinical instrument to act on it. Thank you.